Welcome all. Good morning, good afternoon, good evening, wherever you are in the world today. I hope you're having a nice one. Welcome to the third season and final episode of the Digital Health Institute for Transformation's DHIT Frequency. The DHIT Frequency is a webcast podcast series where health transformers, innovators, and problem solvers come together to talk about best practices, next practices, and all else in the digital health space. I'm Michael Levy, DHIT's president and co-host. I'm co-hosting today with the wonderful Kathy Mallis from the Centre Hospital University Montreal, otherwise known as CHUM, who is the associate CEO and head of innovation in AI. Kathy, always great to be here with you. We had a bit of a month break from seeing each other as we missed you on the last one, but so happy to be with you today. Excited to be back. And though it's our last episode together for this season, hopefully we have more opportunities in the future to do this. It's been amazing.
It's really great to be back with you, Michael. And I listened to. I missed the last session, and I know the people that were presenting with you, and I'm sure it was great. But I had the opportunity to listen to it after. So thank you again for DHIT and yourself and the Government of Québec for inviting me to co-host with you. And I hope that your Thanksgiving was great last week.
Oh, it was interesting. It was certainly great to have some extra time with the family. But we had naturally a much smaller Thanksgiving, just my wife and children, though much smaller. The noise, the decibel levels actually were about right at the same level. I guess that kind of gives you an idea of how wild and crazy my 6-year-old girls are. So we kept the tradition of extraordinarily loud Thanksgiving, consistent, although massively decreased in size.
Well, it's a good sign. It's a good sign. It means that happiness is part of your family. So, however, on a more serious note, I'm crossing my fingers that the trends are more kind to the U.S. as it relates to the post Thanksgiving COVID spike. We had an experience, but I think a bit less than you, because Thanksgiving in the States is as important as Christmas, which is not necessarily the case in Montreal and Quebec. But I hope that the trends are more stable right now on your end. I
mean, that's a great point. It certainly is a point to be mindful of and concerned of. 50 million travelers across the U.S. took flight over Thanksgiving break, and obviously, as you know, it takes a couple of weeks at least to see the net effect of that behavior. So what kind of strategies, what do y'all look, what's happening in Montreal? How are y'all going into the winter? What's your plan right now?
So we canceled Christmas. Unfortunately, canceled Christmas. Canceled the reunions of Christmas. Yesterday, the government of Quebec decided to shut down, to say to the population that there's no family reunion for Christmas. And we're closely following the trends of Thanksgiving, as I said, because Thanksgiving on your side is like Christmas on our side.
Right.
The peaks. If we were watching the number of cases per day, and now we're at 1,500, and it's not really reassuring. So the strategy is to actually more control during the next season for us not to have spikes when we come back from Christmas. The hospitalization are still there, increasing, relatively in control, but some more eclosion, more spreading in the communities. Long-term facilities for elderly more are being hit. So that's why the government decided to be more wise and precautious in recommending to the population not to meet during Christmas in groups.
That is another tough pill to swallow, so to speak. But we've got to do what we've got to do. Well, I'm crossing my fingers as well, and sending best wishes and energy to all those on the front lines, fighting to save lives, fighting for their lives, and those that are fighting to keep, naturally the roof and food on table. Right now, it's extraordinarily difficult time for our society. wherever you are in the world. And on behalf of DHIT and all of our staff, partners, collaborators, we're sending collective best wishes. Well, Kathy, we've got a really exciting program today. We've got one guest, which is not the norm here on the DHIT frequency. Usually we have a number, but we thought it was appropriate considering our guest and considering the many hats and perspectives that he can share to isolate this hour and focus on not just consumer care, but whole person care, care through crisis, and all else. Our guest, Dr. Patrick Quinlan, is got a storied past and I think even more exciting future as we learn about his new venture as he's co-founder and CEO of Hippo Technologies. We'll get into Hippo Technologies a bit later, but I wanted to just, before going through his background, maybe just pause and give thanks to our sponsors and our partners.
Thank you to the Government of Québec and the Hospital Center of University of Montreal. As the coolest hotspot for innovation, we're proud to have the Government of Québec as a disruptive partner.
Thank you. And again, Pat, I'm going to welcome Pat. Pat, it's a great honor to have you. You're not only CEO of a startup right now that is doing some tremendous things, but let me give the audience and our viewers just a little bit of your background. You for about I guess 15 years, decade plus, ran Ochsner Health System down in Louisiana as CEO. You also pretty much ran most every leadership position, it seems like, in the system, from chief medical officer to department head to running their HMO program, et cetera. So, to say that you haven't done a tour of duty across Ochsner Health System is an understatement. You also, navigated the health system through a tremendous crisis down in 2005 in Louisiana, Katrina. Obviously, want to pull on that string a little bit as we navigate this conversation. But then you left Ochsner Health System to become CEO of Hippo Technologies, and in parallel, you're holding a role as lead for Pan American Life Insurance as well. So super interested to hear a little bit about that. But naturally, Healthcare Magazine has in the past recognized you as the most powerful physician executive in the U.S. And one of the most 50 most influential leaders in the U.S. So tremendous insight, tremendous excitement for me and Kathy as it relates to this conversation. And I hope you're doing well through this very challenging time, Pat.
Sure. Thanks, Michael.
It's really impressive background. And I'll call him Pat because I asked him if I can call him Pat before. So quite an impressive background. And as always, dear participants, please feel free to ask questions during our conversation with Pat, and we'll follow them, and we'll if we have time, we'll jump on a couple of them so our guest speaker can actually answer them. So Pat, I'm curious, from your time in Ochsner Health, specifically in 2005 and after, you guided the health system through a crisis. That crisis was Katrina. Can you reflect for a moment and share what was the most difficult part about your experience during this time, and perhaps what was most rewarding coming out from this experience?
Yeah, I'd like to start with the most rewarding. And many people have different views of what happened during Katrina. Usually our views are shaped by what's presented in the media. And I think there was a significant distortion of the reality. Certainly there were terrible times for so many people, but what was lost was the heroic and selfless behavior on the entire population. It was the highlight of my career, actually. I mean, I stayed in my office for 7 weeks, but it was the selflessness of people, their patients, their families. Certainly the people that we work with at Ochsner were just magnificent. And the countless people who helped us from the outside. I mean, the Cajun Navy, people showed up in their boats rescuing people on their own. coordinating with each other, refusing to get anything from our place. We don't want to take your things. We're fine. We're fine. Everyone, we're fine. Just, do you want a shower? Do you want some food? No, we're fine. Over and over and over again. It's just, I'm getting goosebumps thinking about how magnificent people were. People from all walks of life. That was the rule, not the exception. How cooperative people were in very difficult situations. The masses of people going by our place as we helped them evacuate. And the people inside, I remember the patients were more solicitous and concerned for the staff than they were themselves. You know, it was heartwarming. That's what, you know, it brings out the best in people. Unfortunately, I think conflict seems to be what's popular on the media, and good news is just not news. I remember the media, when they would come in, they would try to find something wrong. I said, look around you. You're surrounded by great stories of people just being selfless, and they just weren't interested. They just weren't interested. It was sad. So that was the good thing. We did it. We did it together. The worst was just seeing what happened to the city. It was an eerie feeling going up on the parking deck when the flooding became evident. This hurricane itself wasn't that big a problem. It was just another big hurricane. I mean, damage, but you manage it. But when the flooding occurred, it was eerie to look at the city and only see one red blinking light. That's when you knew new game. So that was a moment for me that I'll always remember. But then people were all up on the deck together, and everyone had resolved to do the right thing. And I think one of the thoughts is, so what do we glean from this in the face of any emergency? And I would say that our response was not an accident. It was the product of design and great people being assisted to do what they can do best. So I would say that if we wanted to think about how we can learn in general about how to respond to disaster, which by definition is unexpected. Otherwise, it's not a disaster, right? And people are so filled with hindsight, but it's always easy when you finally see what it is. And, you know, you can't prepare for everything, right? Because even if you did, it would be the thing you hadn't thought of. So the real question is, I think it was Eisenhower said, you know, plans are worthless, but planning is everything. So how is it that you get into this rhythm of being prepared to work together, to assess together, to act together? And that requires an organization that you build on trust and performance. And that's what we had built. And we'd also built it on practice. It wasn't our first hurricane. It was our first clear, unbelievable, greatest disaster in the history of the U.S. until that time, I think. Maybe Galveston in the turn of the century. But we built it on a performance-based culture that was supportive and objective and had built trust. And we built on a pyramid that was inverted. Our job as leaders was to support those who reported to us, and in turn all the way down to the people on the line. So they knew that we would support them, whatever their decision, and none of this second guessing, backbiting, recrimination that I think is the kind of what's present in organizations that fracture. Now, some they were just overwhelmed, you know. Just if you're completely flooded, what do you do? You know. So I'm not here to criticize any of them. The water only came to our curb, so we were okay. We were on the levee, so it was a little bit higher. We had wells, so we had water. That was preparation from our founder. We had our own water supply, which is huge. We had backup generators and so forth, which failed because of the roof was the waterproof was ripped off, so the junction boxes shorted out. But anyway, it was about, I would recommend tabletop exercise. That helps. Practicing is even better. And then real life drills are best. You learn by doing, you learn by finding points of weakness and deciding how you can help each other and do scenario after scenario for whatever it is. That helps.
So yeah, that's very, very insightful, and you know, from an objective and outsider's perspective, I, you know, born and raised in New Orleans, very intimate with Katrina, and saw, you know, firsthand both the orientation around the problem and disaster and the community coming together, but also the response of Ochsner, both in the immediate needs of the disaster, but also the rebuilding and then the servicing of a region that got decimated for you know, years to come. And now you've got, Ochsner's got quite a footprint across the South in Louisiana. So out of chaos comes opportunity. But let me turn to Kathy for a moment. You're in the middle of a disaster at the moment with COVID in Montreal. The one thing I see that's majorly different is this the idea of a community rallying around the disaster, where it seems like we've got this polarized view of the disaster in itself. Two questions for you. Like, do you see what similarities, what differences are you seeing in this?
So I think bouncing back on what Pat was mentioning, I think in this crisis, there are three factors that influences the mobilization of the community around the disaster. Number one, in the first wave, the disease was unknown, even scientifically. I mean, our protocols were almost absent. We needed to create everything. So the sense of coming together as a community, academic university center community with researchers and professionals, we saw that coming together to develop new things, to answer unknown characteristic of the disease.
Right.
But it was countered by the fear of the disease. I mean, people feared and they were selfless. The people on the front line were selfless, dedicated for patients, but they feared being contaminating and then contaminating their loved ones when they came back home. And I think this is a difference between natural disaster, a bit, not much different, but I think it's a characteristic where you see a tsunami, you see a flooding. I mean, but this disease, you can't see it. So they're selfless, but at the same time, they need to counter their fear of, I can be affected and I can bring it back home.
Right.
So I think this is one difference between the first and the second. And I totally agree with Pat in the sense that the crisis and disaster help organization maintain their resilience and their adaptiveness or agility. You develop coping mechanism when you face crisis. And as an organization, and I'm sure Pat, you can relate, is how can you keep the memory of the coping mechanism? Like this one, there's another crisis, and we will face other crises no matter what. How can we bring back these muscles of coping mechanism to fight back these crises? I don't know if you want to elaborate on that, Pat.
I do. And I want to say from afar, I'm no longer involved with Oxford, but they've done a wonderful job of dealing just with that, with the COVID crisis, and adapted how they practiced, where they put people, et cetera, and mobilized an even larger organization to be supportive. And that's where a larger one has more assets to move than someone who's just a single site that just doesn't. So the more, the better. I will say that the key element is trust. And one of the things that I think is absent, certainly in the national discussion, is practice at real-time decision-making, where you're open about what you know, you're open about what you don't know, you're open about why you decided what you did, and say, we're going to go back and revisit it, but here's why we did it, and here's why we're proceeding. And then rather than a lot of carping and wondering, and why they didn't mean that, they didn't, of course, that's maybe the nature more of politics than of science or of people. But that's what complicates this, is and what was our strength. We'd get up in front of everybody and here's what we know. And we've done this before, though. We went through other crises. So you have to practice this. You don't want to find at the moment of maximum pressure that you really haven't been pressure tested.
But to that point, I mean, it sounds like, and we'll get to this in a moment, but it sounds like the entrepreneurial journey of test, fail fast, and do the best you can with what information you have in the moment in time, right? Yeah. And this entrepreneurial journey, I'll call it growth mindset, if you will. It's an operating system that drives your culture, right? And it's okay not to have the right answer, as long as it's the best answer we could possibly have today, given the information. But tomorrow we might have new information. Is that fair? Yeah.
One thing I learned early on in leadership was it's liberating to say, I don't know. Right. You don't have to fake it, but we'll find out. One of the cliches that we had, we're not perfect, but we like to think we're perfect at getting better. And people will believe you if they say, I don't know, but here's what I know. And but that takes practice, because they've been fed basically, some people, a lifetime of, I want your opinion. And then, of course, we already have the answer. And that was just dressing, window dressing. So if you really say, and then you can openly disagree and say, here's why we do it, but we're going to come back and look at your point of view and just, we'll have an open discussion about, was it the right one? And you learn by making mistakes. You know, that old story about some senior guy being asked, gee, how do you never make any mistakes? And how do you do that? And he says, well, because I made a lot of mistakes and I learned from them. And that's what you do. It's a learning, you know, it's about process improvement. That means open learning, that didn't work. It's okay. It's not personal. It's never personalized. It's on the table. This is a tabletop exercise. It's not about people's value. It's just about ideas.
I love that. Well, let's take that theme and you know, kind of drill down, Pat, on the transition from Ochsner to your new venture, where you're spending the majority of your time today, Hippo Technologies. You know, what was the driver of that of the transition? What's the intent on the focus? Say, where did Hippo Technologies come from?
Sure. Well, I mean, the true story is, you know, as lead director for Pan American Life, I was at one of these directors conventions and I saw the device. I always like prowling around and seeing what the different booths and what people are up to, because they're putting everything on the line. So it's really fun to talk to them. And I saw this device, one of many, but I thought this is perfect for telemedicine, which I had done many years ago at my previous organization in Loveless in New Mexico. It was very successful, but boy, if I had that, it would have been even better. Then I tracked Brian down and found him, and then we decided to come out. Long story how that happened. We came out and just used a mobile computer for telemedicine and telehealth, recognizing that was just the first step on what I'd always thought was the end point, which is to change the way we look and deal with health and the treatment of disease. This is a vehicle, the first step, and that's what the Hive later on that we'll talk about is about, the Health Institute for Virtual Education. It's a mission. That's the purpose of our company, is to make healthcare available for all, and to solve this healthcare crisis that's a slow rolling crisis, you know, like the frog slowly boiling in the pot, never forced to move, and all the way from these huge discrepancy in emerging countries to the Western, same problem. It's a single problem. And and unless you focus on that, we lose, and no one has, to the degree that the threat of it merits. So we can talk about that, but that's what Hippo is about. It's going to be all things virtual, and we can go into how I think that should work and what our philosophy is.
Well, maybe you can share, like, where did the name Hippo come from? To, you know, why Hippo? You may immediately, I think of an animal, but you probably have a different definition.
Right. Well, it came from the Hippocratic Oath, the modern version. As you know, it's an archaic oath that at the time reflects the times, but really it's about serving people and those who care for them in the best way possible. That's our mission, and that's really at the heart of clinical care and social service. Really, that's pro-social behavior. In ours, it's more around the things that influence and affect health, but that can be broad. It can be education. It can be people's station in life, all of that, because it's all related. We like to chop things up to make them understandable, but you know, reality is a little more complicated than that. So anyway, so it was Hippo, and that's the abbreviation for Hippocratic Oath. I must say, in a moment of weakness, we decided we just couldn't resist the little catchy little icon, so we have a hippo, because we do want it practically people to remember. I will say, if you go online, there's a virtual herd of hippos, all kinds of hippos and all kinds of businesses. Ours is Hippo Technologies Inc., and the website is myhippo.life, and we picked life as the source because really it's about life sciences. It's about life in general, more than just .com or something like that, because it again reflects our mission and our purpose. So that's what that's about.
Maybe you can just one example just to create a tangible use case where, you know, have you applied this technology, let's say, to COVID today to support in, you know, do you have a use case you can share there?
Sure. I can actually take you through the evolution, which would demonstrate that in real life. So you learn something about a history at the same time,
Perfect.
Our mentality. So we first sent these devices to, the companies formed prior to the pandemic. And then when it struck in China, we sent devices there because we knew that this remote consultation had so many advantages, and they used it in about 10 hospitals to great advantage.
And just so quickly, the device, can you describe the device?
Sure, it's a head-worn tablet with a 16 megapixel camera, with a hard drive, and an optical piece, a viewer that's about the equivalent when you look at it of a 7-inch tablet. So it has your desktop and all the different little icons that you can click onto things. There's several things that make it compelling. First of all, it's a rugged tool, but there are 50,000 of these out there and 0.5% failure rate. So I know in medicine, if it's not rugged, it's going to break and people won't use it. Rugged, threshold issue. Secondly, it's voice controlled, so you're hands-free. You can actually do medicine as you were trained and as you prefer, rather than having some device off to the side. Mabel, go get the camera, go, put it on a cart and get an odd angle. The third is this camera gives you a you are there perspective for the remote viewer. And you can do it real time, so you get this real-time consultation if you need it, or you can store and forward, so you can do asynchronous, which is important for scheduling. And you can call down information from the cloud, from your hard drive, or your mentor can send it to you on your eyepiece. So it's a way of getting multiple feeds at the point of service. And that's part of the beauty is I get into who's the customer, and we say our focus is on the end users, and that is the patient and the people who take care of them, making sure it meets or exceeds their expectations. Right. So they'll say, wow, this makes my life better. So much of technology kind of helps the system, but occurs in many ways at the expense of people who actually have to use it on the line. So we're very on the line focused, and that's how all these things come together and converge around what would work for the patient, the member, and the clinician to make sure though that as we solve that problem, we don't create a new set of problems up somewhere for somebody else. It's actually solve a problem, and to do that, we have to have an intricate understanding of the use case. Tell me every little step about it, so you don't have these fumbles, these things that sounds good but don't work. And then, we've seen that in so many places, kind of, but not really, or the hot potato gets passed off to somebody else and they've got the problem. That's not problem solving, that's problem shifting. And that's what happens in healthcare so much, including the financing.
Most definitely. So use case, COVID, I can imagine, now we're talking about distance, remote, there's got to be a quarantine scenario in here. Tell us.
I'm sorry, I digress.
No worries.
The problem with this virtual care is it's limited only, and the way we use it with the Hippo virtual care system, it's limited by our imagination. You can go anywhere. So focus is really important. So in the case of Wuhan, what happened was they were able to protect vulnerable and scarce people, the specialists, from being exposed in the patient's room, right? So they could consult and be like they were there. At the same time, they weren't changing their PPE all the time. So at that time, PPE was very scarce. So it's all about the design. What are you trying to accomplish, and how are you going to do it in a way that makes things better? So in this case, you protected the vulnerable and you save PPE, and you're able to have something of a workforce multiplier, because when you're consulting, go 1, 1, 1, 1. You don't have to keep changing. And so speed is everything when a system has been overwhelmed by demand, which is what people have suffered through everywhere that has occurred in significant numbers. After that, we went to Africa to do our first installation to prove, basically it's collaboration and inspection. But to put it in sort of groups to make it understandable, it's about consulting, it's about teaching, it's about proctoring, and it's about rounding. Those are the sort of typical clinical applications that we used in Africa for 2 reasons. One, we want to show that it can be done in difficult situations. And 2, we believe that Africa, along with much of Asia and South and Central America, where this kind of technology is needed to meet and solve problems that right now seem to be intractable. They're not, if we do it right, through manpower multiplication. So we proved it there, and then we've marched it through. It's used in Norway. It was used at the Suburban Hospital in Johns Hopkins. It's being used in Australia and Southeast Asia, and it's global, which is a real challenge if you want to get sleep, managing all of that time zone management. But it's great, so it's just taken off. Yeah,
it's amazing. So tell us more about, within Hippo Technologies, there's the Hive, which I understand stands for Healthcare Institute for Virtual Education. You spoke about it just before. Could you tell us more about the goal? And how do you see this working in collaboration with your vision of Hippo and the future of care?
Yes, well, thanks for asking that. So there's the practical immediate part, which is it's a place for all things virtual, or people from different points of interest, starting with students. We think that's the future, right? It's about students of all kinds, because they're mission oriented. They want to do something that matters, and also enhance their own careers and find out something where they could really apply themselves. So our goal is to have 2 million members of students. There are 2 million medical students in the world. That's the nice thing about technology. We don't have limitations that way. Our catchphrase that we coined is networks without borders and knowledge without boundaries. Mm-hmm. So it is a knowledge network. And how do you want to apply it? Take knowledge where it's needed, to where it's technology where it resides, to where it's needed, how and when and where the user says, here's what will help me. Thank you very much. So the Hive then is a place of ideas, and segregating those in a way, aggregating them around industry, around clinicians, around researchers, around teachers, around education, around students, is going to be our art. But then having them collaborate in ways that, together, when you have group thinking, group sourcing, you can just learn so much and motivate people to say, this can actually work. It's not an extension of what we do today. The trap is, like when computerization first came out, is to automate your old processes. Mm-hmm. That's a trap. It's comfortable. You just missed the opportunity. Virtual care is something to do things entirely differently. And that's part of what we want to promote. But underneath it is the higher purpose of medicine. Is our purpose. It is a mission to understand what the threat to health is, how we can fix it. And we have a model to do that. And starting a movement with all of these people coming together, when you want to, and movements have faster and faster life cycles now. I think about Ralph Nader, the first one, car safety, what's wrong with this guy's a nut? Now it's, you won't get in a car that doesn't have a seatbelt, right? And that happened over a generation or so. Social movements, faster and faster. So the time is right now for a medical transformation, and truly transformation. Often transformation means, hey, a nice new marginal improvement. We're talking about changing the fundamental approach to health and disease. We can do it.
On that point,
and that's the mission. So we're going to create a parade that then the leaders can get in front of them and say, hey, this is what we need to do, and it becomes conventional wisdom.
I'll flip it to you, Kathy. CHUM, Montreal, healthcare. How much in alignment are you as an organization, as a strategic, kind of leadership group in, the orientation of virtual care as our future, and the kind of reorientation of our system as we know it, so to speak, to actually, live by the opportunities and the potential of the future of care through virtual narrative?
Well, virtual care is part of our strategic planning. I mean, we have no choice. I mean, one day hospitals won't be full. I mean, we're going to keep maybe intensive care, operation rooms, but
like that.
Yeah, but I mean, we have no choice but to start, and we did. But I mean, all organizations across the world should actually include in their strategic transformation how we can offer care beyond the wall of a hospital. And how to offer proximity care to the communities where they are, either at work, either at home. And so the first answer to your question is including this in our strategic transformation. Number two, I totally agree with Pat that lifelong learning around that is crucial. Learning in practice. I mean, yes, the future of health are students, and you need strategies to actually train them differently. Whether it be nurses or doctors or physiotherapists that are currently in academia, still in the university, we have the chance to develop new competencies. But the ones that are in the hospital or in other facilities, how to actually accompany them to transform the way they teach, they learn. Pat mentioned a very important point, which is you can't redesign care pathways by just adding technologies. It's a new pathway, how to integrate virtual care, virtual teaching, lifelong learning within current practice, and not just add things to the current pathway and workflow, but redesigning it. Because, and this is why the triple aim went to the quadruple aim. They realized that we introduced technologies and burnout of doctors and nurses increased. I mean,
right.
Obviously, you just added technologies without redesigning.
Right.
And I think if you want to achieve true transformation through virtual care that passes through education, we really need to always think how to redesign the way we work, redesign the way we teach, redesign the way we do research, and assess impact of technologies into care if we want to succeed.
Could I, Michael and Kathy, could I get on the soapbox just for a minute and say that what we're talking about, though, is a major modification of the way we do things. Our philosophy is different. And it sounds the same, but it's different because everyone is sincere when they say, you know, this is patient-centered. If it were really patient-centered, we wouldn't care how they got it. So our view is that the problem we're trying to solve that you never hear about is the disease load in the country, the disease burden. How many people are sick with how many diseases of what severity? That is the problem we're trying to solve. And of the three determinants of the disease load, it's environmental, it's genetics, and it's lifestyle. The biggest and the one most amenable to change is lifestyle. We have not made lifestyle change a national priority, which means that we have not made solving the problem a national priority, which means we are on the same path. Even if we increase the reach and the efficiency of the disease management part through virtual care, the customer, in my mind, is the individual. And our job is to make sure that they understand their risk factors, and not just know, but then act on what those risk factors are. And they live in an environment that enables that. That should be the national priority. And then around that, you surround them with virtual care of all kinds and only have physical care when you have to. Imagine if everyone knew what their risk factors were. Imagine if they knew how to manage diabetes, hypertension, inactivity, alcohol, things like that, the major drivers of disease. Imagine if we eliminated smoking in the world. That sort of thing, but it isn't that just tell people to do it. They do the things because of very powerful reasons. We need to understand what they are and solve that. Telling someone to eat more almonds and be healthy and exercise is futile. Understand their motives and enable them to change it themselves in a way that's mass customization, very personal, very addictive, just like Facebook, except it's all about you. It's all about information, about how you can change your behaviors. That's the difference. Virtual care around it, and only go to physical care when you have to. True patient-centered means what do they want, how do they want it, and give it to them. Not it's an extension of the existing way we do things. That's a fundamental change.
I mean, correct me if I'm wrong, and I stumbled upon this article that you wrote in The Hive called "The Future of Healthcare: Polymorphic Medicine." Right. Is this what we're talking about? Let me just read. You know, I'm gonna actually read this so I don't butcher it. But polymorphic medicine represents a paradigm shift towards the next evolution of healthcare. If the first decade of the 21st century was characterized by systemization of healthcare, with the introduction of electronic medical records, and the last decade saw the rise of genomic-based personalized medicine, we are now on the cusp of transitioning to the next phase, a rehumanization of healthcare with the system oriented around the individual, enabled by technology, and informed by advanced analytics. Pretty much summed it up.
The idea of polymorphic.
Can you
we chose the term.
Expand on that?
Yeah, polymorphic, we chose it because it means many shapes. So it isn't one size. Here we have a hospital, we have a clinic. We're going to reach out to you and help make it more convenient, but it's still institution and bricks and mortar based. It should be virtual and should be tailored to what you need. Some people need one thing, some people another, and we can bring that to them, recognizing there are limitations, but it's going to be the 80-20 rule. You can get most of it done, good enough. You know, perfect is always the enemy of good. We have people, well, but you might miss something. How much are you going to miss when you don't even see people? Right? What are you going to miss with delayed diagnoses, with misdiagnoses? All of that cost usually is not part of it because as humans, that's the way we think. We think about what's in front of us and either or sort of thinking. And that's just the way we're wired as people. We need to become more comprehensive and more integrated, but it really needs to be, we give you what and how, when you need it, where you're in your place of preference, because that's immediate. That's the timing is right. It's not later, which is what we do with lifestyle modification. Oh, I'm going to do that next week. Oh, it's going to be, New Year's is coming up. That's not the way it's going to work. It's going to be every day, because you want it, you understand it, and you use it. That's an art. So that's, Cotter would say it's about change management. It has to be authentic leadership. It has to be open leadership. We have to state the problem as huge as it is. No Western country has beaten this, right? It's every year it costs a little bit more for every person. Surprise, we haven't attacked the disease load.
Right.
Right? We're measuring the wrong thing. How many times have you heard, well, we spend so much on healthcare, but look at these results. It's because those results are unrelated to public health, totally unrelated. And we keep saying that. I'm thinking, well, you really don't understand, do you? You don't understand. We're focusing on sick care, not true primary preventive medicine, starting with the individual, not early diagnosis. All that's great. All we need to do, all that super value-based treatment. But unless we get into focus on prevention, and the less the country has, the more important it becomes, right? In these underdeveloped countries, and when I was consultant in Saudi Arabia, said you'll never build enough, train enough, fast enough to catch up with this disease load, which has almost an exponential growth because of the concentration of disease in a relative few, who maybe use 50 times. 5% of the people use half the resources. As that expands, you'll never catch up with the multiplier by adding.
It makes total sense.
So we need to stop the migration into the super user group. Yeah.
It makes total sense what you're saying, Pat. It's, however, very hard.
It does make sense.
It does. And however, it's hard to accomplish. This transformation is deep. And naturally, COVID has accelerated this transformation and amplified the adoption of this reality in part. That said, business models or payment model transformation seems to be key ingredient to ensure long-lasting transformation. So, Pat, in your role now as a lead director for Pan America Life Insurance Group, are you working on strategies or programs that align this way of thinking and this transformation that you're describing? Or are you seeing example of this elsewhere?
Sure. Now, as lead director, I'm not lead of the company. That's the CEO and president who's doing a fabulous job. It's just about how the directors work. But I can tell you, we're united around the idea of prevention and health. That's the nature of insurance, right? Reduce risk. In this case, it's reduce the risk to the individual. And there's a lot of effort on the part of Pan American Life to reach into people, such as Hola Doctor, which is the doctor. It's a program around healthy eating. You can tell people to eat healthy, but give them the recipes, make it exciting, make it doable, make it accessible with simple ingredients. And that's one example of, we know that diet has so much to do with people's health, hypertension, diabetes, obesity. You try to find these practical programs that have multiple benefits over time that people will accept. Everything that we do in terms of the kinds of activities we've talked about have to be socially acceptable. Forcing it, pressing it, blaming has no place. People have very good reasons for doing what they do. We need to say, hey, we've got a better reason for you, because actually it's going to affect you. It's going to affect your children. It's going to affect your company. It's going to affect your country. In the US, we have such a problem because it's basically sucking all the resources out of other things that are needed. And we end up with a zero-sum game. That means people have to fight. We could save $1 trillion a year very quickly if we tackled this health style issue in a very constructive, supportive way. Smoking, hey, look, we're all culpable in that we allowed it to occur. We allowed this addiction cycle, which was, you can clearly see in discovery that wasn't an accident, right? It's actually promoted to people. And how do we help them out of that?
Pat, I'm curious to know, you said that, for example, because lifestyle is a change of behavior. So you need techniques, like you said, make
behavior
it fun.
Change, right?
Yeah, exactly. Gamify it, for example, make it fun.
Sure.
One characteristic, I didn't hear you talk about it, is the literacy. Can I have your 2 cents on, in order to change behaviors and adopt good lifestyle, you need to understand what
be receptive, right? Be able to see information.
Could you tell me more about how you attack low level of literacy for vulnerable population, for example?
Well, but we had 2 programs we started when I was at Oxford. I got tired of talking to myself in the shower and said, what are we going to do differently about this? So we partnered with 2 at-risk high schools and said, how do we change behaviors there? And that you had to get into the school. So we put a nurse practitioner there, so take care of medical problems. But then we work with administration to say, how can we enlighten people and motivate these young kids? The veneer was, oh, well, you can't change adults. We'll just change the next generation. And it was called Change the Kids, Change the Future. But I'll tell you, you'll never meet a better change agent than a kid in a family, right? Dad, why are you smoking? Do you want to die? Totally. One person told me that. He stopped smoking immediately. So you never know when this happens. So anyway, they had fairs. They got into it. I was shocked. I thought it would be more of just a kind of a science lab sort of thing, and maybe would work. The administration embraced it because the idea was, how do you improve the health of everybody inside those four walls? Well, it was a big success. Then we found out with these children, about a third of them were responsible for the meals at home. People say, oh, it's terrible. Great. We've got our change agents at the controls. So we had a chop program where we teach them how to chop, to shop and cook in a healthy way, not in ways people don't like it. If they don't like it, it's over, right? That's the social acceptance part. Nobody, you want to look forward to eating. So anyway, the point is that there are many, you have to be flexible. You have to understand the individual and meet their needs. You can't, lecturing isn't going to get it. Now, my personal soapbox issue is that education as a module is a mistake, that we need to indoctrinate our students in health. So when you're writing about math, I don't care when the trains, you know, what the formula is for that. Let's start talking about diabetes. Let's talk about serum glucose. Let's talk about hypertension. Weave that into everything. Weave it into, you want to write an essay? How about Johnny went through the windshield because they weren't wearing a seatbelt? What did that do to the family? What about dad died from smoking, and what did that do to the family? You know, you could think of millions of things like that, to where when they're out, they know, and they know all the tricks that how they're being manipulated, and that's what you should do if you're serious about a national change.
And I love it. And I think it gets back to the idea of literacy being, you know, the first is awareness, then it's about acceptance, then it's about action. And we have a gap first and foremost around awareness. Like, you know, back to you know, you look at COVID here, and you look at the lack of data and the lack of coordination across our communities, just in the state of North Carolina, let alone country and the world. And you know, we have imbalance in our practices, in our knowledge gaps, because we don't have access, we don't have awareness of what is available, let alone, you know, have the ability to activate and take action on that available information. So literacy is a critical area that we need to focus on as we certainly mature in this 21st century from a data, a digital, and pure kind of resource opportunity perspective.
Michael, if I could though,
please.
To me, this is the crux of the issue, is that change management requires enormous effort at every level. So getting people together, leaders of all kinds, to say, listen, here's why it's important. And there are different things, different areas of different importance to different people. So in the case of, it may be, do you want to keep Social Security, or do you want all the money sucked out of that? It gets worse and worse. Do you like Medicare? Do you want to keep that? Medicaid, do you want to keep that? What about education? What about the dollars that should be going in there and aren't? What about national security? It's hard to even find people who now qualify. So you find things that are really wedge issues for people. Oh, I get it. Your own health, that's the last thing people think of, because, you know, denial is a wonderful way of doing things. And you do it because you did it. And Millie lived for 90, even though she smoked. Well, that's Millie. She's bulletproof, but you aren't, right? So anyway, that's the idea, that if we want to really transform health, and that's what the HIBE is about, bringing people in from all walks, all influencers. There are a few people, a few organizations folks tend to listen to, find out and say, listen, this is for our common good, to preserve our way of life and make it better. So much of what's collapsing is because of the cost of healthcare. People now work just to be covered, right? I mean, say, oh, gee, we need more income. How about lowering the cost? That goes a long way.
Well, to that point, let's take this opportunity. I'm gonna introduce a section that we introduced this season called the rapid fire. It's really, you know, three questions.
Let me brace myself. I'm ready.
Was that? Yeah.
I'm ready.
I'll just tie, you know, what you just said to, it was the second question, but it'll be the first question here. You know, I'm looking for a one-word answer or a one-sentence answer. Really, it's supposed to elicit your reactions, but this is a reaction. This should be a one or two word answer, but it ties to this idea of medical, you know, the medical costs increasing, and the nature of those costs, how they make their way to all of our beneficiaries and individuals. But anyway, here's the set. According to medical trends around the world, and this is actually pulled from the Pan American International site. So thanks for your a little help with this stat. But according to medical trends around the world, 21 of 29 countries studied, medical inflation was 2 times as high as general inflation.
Right. These are all different views of what is a common problem that has not been identified sufficiently as the cause, and therefore we're not curing it. The cause is the disease load or the disease burden. And until you do that, it's going to get worse. And as a fun fact, if you were to do a scatter diagram and see where how nations differ by cost, it tracks very nicely to the national wealth. The more you have, the more you spend on health, because what could be more important? And that's the trap of getting sucked into just a disease-oriented approach. It's gripping, it's real, it's personal, and that's, of course, it's like there's a fire in the house. Of course, you're going to get after that, but you didn't say, no, where's the next fire coming from? How are we going to prevent that? So that's the issue. No one's taking on. In fact, Michael, if you were to ask 50 people, what's the problem with healthcare? You would get 50 versions of the symptoms of this disease load. It would not say, the disease burden's too high. What are we doing about that? Why isn't that our number one KPI as a nation? Show me one. Doesn't exist. I don't think. I'd love to hear about it. I'd love to do what they do.
So that kind of ties into the next question, which you may just say that, answer that, which is, what do you know that we should know? Give us one thing, one stat, one aspect of your world, Pat, that you feel everybody should know, if there is.
It's the disease load is the problem we're trying to solve, right? Yeah. And that the good news and the difficult news is that, or the challenge is that lifestyle is of the three, genetics, and environment, and lifestyle. Lifestyle is probably the biggest driver, so the most amenable to change. And of course, it's artificial to say there are three. Often they intersect. So we're going to work on all three, but the one you can start with tomorrow is I'm going to take care of myself. In the process, I'm going to take care of my family, my community, and the country. Now, how do I do that? And that's where the national part could come in a very supportive way and said, well, do you understand your personal risk factors?
Right.
And then if you do, then here's what you can do to modify those. If you have prostate cancer in your family, probably not really guard against obesity. It's a major driver. If you have breast cancer, really ought to look at obesity. Simple things.
Right.
Not the scientific stuff, not the highly technological stuff. Blood pressure,
So,
how many people have hypertension and diabetes?
So I just put a magic wand in your hand. You just stated the problem. What would you do with that magic wand? There it is.
Now that's tempting.
What do you? No, where are you going with that magic wand? You got one swing.
No, what I would do is I would create a system where the individual is absolutely informed about their individual risk factors. They're absolutely motivated successfully over time to do it. And they live in that greater environment that enables their ability to act on it. And that greater environment is really, that's the role of government. That's the role of policy. So, we all know that another fun fact is that at least the data of the past was behaviors in medicine are influenced maybe 10% by what happens in the doctor's office. The rest is where they live. So the idea is, can we, the duty for that, it's in commerce. Is everyone in their business supporting health? That's your job. What about government? Everyone in government, an employee, that's your job. And it's also as government to create those policies that enable behaviors. Religion, healthy body, healthy mind. Let's all, helping your neighbor, helping your fellow person in church is supposed to be your duty. How can we do that, right? And play. How about the athletes saying, all this stuff's neat, but listen, I want you to take care of yourself, and have examples of that. So every place in society where you learn your habits, let's make sure they're learning good ones and make it easy to do the right thing and hard to do the wrong thing.
Well, I appreciate that, Pat, because, it was about maybe a year and a half ago when I was introduced to Dr. Fabrice Brunet and Kathy and the CHUM and Montreal's ecosystem and the culture. And I felt like that ideology, if you will, or that culture, though imperfect naturally, but we're so far forward from the U.S. system and from what I experienced from our community and from our culture as it relates to the multi-components of this ecosystem: government, industry, public health, community wellness. It felt so clear and so tangible, Kathy and Pat, that was a priority, and it was understood. But when I flew back home to the U.S. it dissolved again. And I felt like there was no understanding and no alignment and responsibility of around what a kind of connected and aligned ecosystem kind of looks like. And Kathy, you can keep me honest. I mean, this is your goal. This is what y'all are working towards. And I just feel like, and why we've at DHIT, spent time nurturing this relationship, and thankfully, CHUM in Quebec, and they've been very open. It's because, I feel like we have so much to learn and so much to extract from the way they operate this ecosystem that supports the community versus the disparate nature of our system in the U.S. that looks as at each other as customers and revenue streams.
Yes, definitely. And what you just said, Michael, and what Pat said, which is for me, the diagram of Venn, you have environment, genetics, and lifestyle. And we in Montreal, Quebec, and Canada are aware of this. Now, the challenge is to actually say that curing and caring is maybe as important as prevention and health promotion. And the investments are still not there. That's the challenge in Quebec and Canada. We're still a hospital-centric, cure-centric, care-centric model, but we are aware of the importance of going beyond through an ecosystem approach to tackle these three problems. The dollars are not following.
Yes.
If I could expand on that a little bit, the dollars are there because it doesn't cost much if you do it right.
Right.
Motivating, changing your policy. It's a policy change. It's policy change. Policy change isn't very expensive. We're not talking about building more things. I mean, it's public health. United States, one reason our disease load is so high that we have underemphasized public health. Anybody in public health would say, yeah, I get what they're talking about. Nobody's listening. And that's the leadership void. Right. Because people are so sucked into the disease side. It's not either or. Of course, it's both. But this other both with technology, we can have mass customization for people. Yeah. We can have your own Facebook, your own health book account, where all that data feed is going to come into you and tell you what you're really doing versus what you think you're doing, and array it against your risk factors. And that could be happening on a regular basis.
That's right.
That isn't expensive. That is dirt cheap if you look at per member per month cost.
Totally.
Dirt cheap.
Totally. Well, let's take this opportunity first off, Pat, to thank you. It's a couple minutes from the top of the hour, so our session's coming to a close. Something tells me the three of us are going to be on calls going forward as we work to solve against this major problem, because all organizations are fundamentally aligned with what the problem is. And we're working together. This is the last episode of season 3 for the DHIT Frequency, but it is not the end of our relationship with CHUM and Montreal and Hippo Technologies and Pat. We're going to be producing more program and certainly more concerted, organized efforts to build infrastructure for our future and actualize that infrastructure in our community to address the problems that we are focused on and have been talking about through this episode. Patrick, Dr. Pat Quinlan, thank you so much. It was a phenomenal session. Kathy, just the biggest hug and heart to heart. I'm so thankful for you accepting the invitation to join this season. And it's been just a tremendous pleasure. I can't wait to figure out what we're going to do next together and include the rest of the community along the way. So thank you both so much.
Thank you
for the opportunity. Appreciate it.
Well, on behalf of DHIT, the Center Hospital University of Montreal, Government of Quebec, all of our partners, staff, friends, colleagues, and those in the world that care about what we care about. Until next time, we're tuning out. Cheers.